Hello and welcome. Today we will discuss female hormonal contraceptive drugs, which are among the most widely prescribed medications worldwide. However, modern hormonal contraceptives are not used only for prevention of pregnancy. They are also used for menstrual disorders, polycystic ovary syndrome, dysmenorrhea, endometriosis, acne, and even long-term reduction of certain cancers. So, let's start. The learning objectives are shown. Please take a look. Contraceptives can broadly be divided into physical, hormonal, and surgical methods. Physical methods include condoms, diaphragms, cervical caps, spermicides, and related barrier techniques. Hormonal methods include oral contraceptive pills, injectables, implants, intrauterine systems, and emergency contraceptives. Surgical methods include tubal ligation and vasectomy. Although this lecture focuses mainly on hormonal methods, it is important to understand the overall classification because contraceptive counseling requires individualized patient-centered selection. Different methods vary in efficacy, reversibility, convenience, adverse effects, and patient acceptability. Before discussing hormonal contraceptives, we first need to understand the normal ovarian and uterine cycles. Pulsatile GnRH release stimulates pituitary secretion of LH and FSH. FSH supports follicular development and estrogen production. Around mid-cycle, rising estrogen levels trigger the LH surge, which induces ovulation. After ovulation, the corpus luteum produces progesterone. Estrogen and progesterone then exert negative feedback inhibition on the hypothalamo-pituitary-ovarian axis. The uterine endometrium simultaneously undergoes proliferative and secretory changes. This slide is extremely important because hormonal contraceptives largely work by flattening these cyclical hormonal fluctuations and preventing the LH surge. Synthetic estrogens and progestins are long-acting analogues of natural reproductive hormones. Natural hormones themselves are useful in hormone replacement therapy but are generally not ideal contraceptives because of short duration and inadequate suppression of ovulation. Contraceptive formulations use synthetic compounds with greater oral bioavailability and longer duration of action. Combined oral contraceptives usually contain both estrogen and progestin and are taken daily. Progestin-only injectables are long-acting and are especially useful during lactation because they do not significantly reduce milk production. Progestin-releasing intrauterine systems provide highly localized long-term contraception. This slide highlights the diversity of modern hormonal contraceptive delivery systems. Emergency contraceptives are used after unprotected intercourse. Most commonly, they involve high-dose progestins such as levonorgestrel. These drugs mainly work by delaying or inhibiting ovulation and by making cervical mucus unfavorable for sperm motility. Mifepristone acts differently because it antagonizes progesterone receptors and interferes with the pregnancy-supporting role of progesterone. Danazol historically had limited post-coital contraceptive use because of suppression of gonadotropin release and interference with progesterone physiology. Emergency contraception is therefore fundamentally time-sensitive endocrine intervention. This slide summarizes the classification of synthetic estrogens and progestins. Ethinyl estradiol remains the prototype synthetic estrogen in many combined oral contraceptives. Progestins may belong to pregnanes, estranes, gonanes, or spironolactone-derived compounds. Older estranes such as norethindrone possess relatively greater androgenic activity. Gonanes such as levonorgestrel and desogestrel are more potent and generally better tolerated. Drospirenone is particularly interesting because it is derived from spironolactone and possesses anti-mineralocorticoid and anti-androgenic properties. This classification is clinically important because different progestins produce different metabolic and androgenic adverse effect profiles. First-generation progestins were the earliest orally active synthetic contraceptive agents. Second-generation agents such as levonorgestrel were developed to improve contraceptive potency at lower doses. However, these drugs were relatively androgenic. Third-generation progestins such as desogestrel and norgestimate were designed to reduce androgenic adverse effects. Fourth-generation compounds such as drospirenone attempt to mimic natural progesterone more closely while minimizing androgenic and mineralocorticoid adverse effects. However, notice the important clinical trade-off. Lower androgenicity may come with relatively increased venous thromboembolic risk. This slide beautifully demonstrates how drug development continuously balances efficacy against adverse effects. This schematic graph compares normal hormonal cycling with combined oral contraceptives and progestin-only regimens. Normally, estrogen rises during the follicular phase and triggers the LH surge leading to ovulation. Combined oral contraceptives flatten these hormonal fluctuations. Continuous estrogen and progestin exposure suppress the hypothalamo-pituitary-ovarian axis through negative feedback. As a result, the LH surge does not occur and ovulation is prevented. Progestin-only methods mainly act by suppressing ovulation variably, thickening cervical mucus, and altering the endometrium. This slide is extremely high yield because it transforms abstract endocrine physiology into understandable contraceptive pharmacology. Hormonal contraceptives exist in multiple formulations. Combined oral contraceptives contain both estrogen and progestin. Monophasic pills contain fixed hormone ratios throughout the cycle. Biphasic and triphasic pills attempt to mimic natural hormonal fluctuations more closely. Progestin-only methods include oral pills, injectables, and intrauterine systems. Emergency contraceptives are taken after intercourse. An important principle is that different formulations are selected according to patient-specific needs such as adherence, lactation status, thromboembolic risk, and preference. Ethinyl estradiol combined with levonorgestrel is among the most commonly used oral contraceptives. Desogestrel-containing formulations provide lower androgenic adverse effects. Long-acting injectable progestins such as depot-medroxyprogesterone acetate are administered every 3 months. Norethisterone enanthate is a very common injectable option. Emergency contraception with levonorgestrel should ideally be taken within 72 hours after intercourse. This slide converts pharmacological concepts into practical prescribing examples. This table compares the use of estrogens and progestins. Color coding helps quickly compare a particular use. Please take time to dive into it. The key highlights are as follows. All are either estrogens or progestins. HRT involves natural hormones, while contraception needs stronger and long-acting synthetic hormones. For example, estradiol in HRT, ethinyl estradiol in contraception. Progesterone for HRT, levonorgestrel in contraception. There are only a few exceptions to this approach. For example, MPA for both, but at a different dose. This slide reinforces one of the most important principles in pharmacology. The clinical effect of a drug depends not only on the drug itself, but also on dose, route, and therapeutic context. The adverse effects are quite predictable. Combined oral contraceptives commonly produce nausea, mild headache, mood changes, and breast tenderness. Progestin-only methods often cause irregular spotting and unpredictable bleeding patterns. Injectable contraceptives may cause weight gain, delayed return to fertility, and reversible reduction in bone mineral density. Intrauterine systems may initially produce pelvic cramping and irregular spotting before eventual amenorrhea develops. Emergency contraceptives may cause nausea, fatigue, and temporary menstrual irregularities. An important clinical point is that many adverse effects improve with continued use, and proper counseling greatly improves compliance. Estrogens increase hepatic synthesis of clotting factors and produce a hypercoagulable state. This increases risk of deep vein thrombosis, pulmonary embolism, myocardial infarction, and stroke. Notice the coagulation cascade shown in the diagram. Estrogens increase several clotting factors while reducing natural anticoagulants such as antithrombin 3 and protein S. The slide also explains the factor V paradox. Although estrogen slightly reduces factor V levels quantitatively, the anticoagulant regulatory role of factor V becomes impaired because of a concomitantly reduced protein S activity. This leaves factor VIII activity relatively unchecked and contributes further to thrombosis risk. Hormonal contraceptives are widely used beyond contraception. In menorrhagia, levonorgestrel-releasing intrauterine systems and combined oral contraceptives reduce endometrial proliferation and significantly reduce menstrual blood loss. In dysmenorrhea, suppression of ovulation reduces endometrial prostaglandin production and therefore decreases menstrual pain. Monophasic contraceptives may also stabilize hormonal fluctuations in premenstrual dysphoric disorder and reduce severe mood symptoms. Thus, hormonal contraceptives are important therapeutic endocrine regulators rather than merely fertility control agents. Combined oral contraceptives are commonly used in polycystic ovary syndrome when pregnancy is not desired. Suppression of the hypothalamo-pituitary-ovarian axis helps regulate irregular cycles. Progestins such as drospirenone and norgestimate reduce androgenic symptoms including acne and hirsutism. Contraceptives also suppress formation of functional ovarian cysts. In endometriosis, hormonal suppression reduces ectopic endometrial tissue activity and painful bleeding. Although contraceptives do not directly eliminate fibroids, they may reduce associated bleeding symptoms. Let's visualize the interaction between normal hormonal cycle, contraception and PCOS. The first panel shows the normal ovarian cycle with coordinated fluctuations of FSH, LH, estrogen, progesterone, and inhibins. The second panel demonstrates how hormonal contraceptives flatten hormonal cycling through continuous negative feedback suppression. The third panel illustrates polycystic ovary syndrome. Notice the abnormal LH predominance, androgen excess, elevated AMH, impaired ovulation, and multiple small ovarian follicles. This slide elegantly integrates normal physiology, contraceptive pharmacology, and disease pathophysiology into a single visual framework. One of the most important long-term benefits of combined oral contraceptives is reduction of certain cancers. 5 years of combined oral contraceptive use may reduce ovarian cancer risk by approximately 50%. Endometrial cancer risk is also substantially reduced because continuous endometrial thinning prevents hyperplasia. Interestingly, colorectal cancer risk may also decrease modestly. To conclude, female hormonal contraceptives represent one of the most important applications of endocrine pharmacology. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!